Good evening. Thank you all for coming and joining this presentation by Dr. Mario Vaz. I'm also very happy that there are several participants who are actually witnessing this session online. Before we start, I'd like to say that I'm very happy that our Associate Director College and Research Institute, Reverend Father Charles, has joined us. Father, I request you to say a couple of words before we start. Yes.
Dr. Rebecca and Dr. Mario Vaz. Dr. Mario Vaz has been a champion of ethics in St. John's and also the history of St. John's he has written. And I got to know him a few years when I came here for a conference at the 8th National Bioethics Conference, 50th National Bioethics Conference. And I'm extremely happy that Dr. Mario Vaz has consented to present this topic, public health ethics, to our esteemed audience here. And I hope to listen to you. Thank you. Welcome.
Thank you so much, Reverend Father Charles. I'd like to say that Father Charles himself is an expert in ethics, and we're really privileged that he's joining us today. And on behalf of the Nutrition Society of India, Bangalore chapter, and the Division of Nutrition, I once again welcome you all. It is my privilege that Dr. Mario Vaz is giving the first session here in this Pope Paul Auditorium on behalf of the Nutrition Society of India. Professor Mario Vaz is a professor of physiology at the International Medical School at Ramaya University campus in Bangalore. He did his schooling in St. Joseph's North Point, Darjeeling, where he was exposed to very enlightened teachers with various interests. He did his MBBS at St. John's Medical College, and after his graduation in medicine, he worked at the EMOS Swiss Leprosy Project, where he was responsible for the implementation of the revised National Leprosy Eradication Program in 800 villages and 500,000 people. It was here that he started encountering ethical issues at a population level. Following his post-graduation, he has been involved in several laboratory and population-based research at St. John's. Professor Vaz has been associated with St. John's for several decades since his MBBS. He was, as Father mentioned, he was in the Humanities Division of SJRI, leading the division, and he has a particular interest in humanities and health and with a particular focus on history of medicine. It is our pleasure to have Professor Mario Vaz back in St. John's and speak to us about public health ethics. Thank you.
Thank you, Professor Rebecca. It's a pleasure to meet many old friends here. I'm going to, although I know this is a function of the Nutrition Society of India, I actually come with a disclaimer. I'm not going to be talking about nutrition. I'm going to be talking about public health ethics through the lens of history. But I am sure that as I talk about public health ethics, you will find things which you will be able to relate to in terms of your own fields or expertise. So what is the purpose of ethical analysis? This Carlo Petrini wrote a wonderful article on this in the American Journal of Public Health. And he outlined that there were essentially three purposes. The first was to decide what is right or good, and then to determine how we know that it is right or good, and finally, how do we act in accordance with what is right or good. I want to take you back in time to almost a little over 100 years ago. We are all people who have gone through a major pandemic. And this was the earlier pandemic, the Spanish flu, which occurred towards the end of the First World War and then continued for several years after that. The war, very few people realize that the end of the First World War between 1914 and 1918 was in part decided by the Spanish flu. America entered the war late, and there were camps which had soldiers prepared for the American Expeditionary Force, which then sailed across the Atlantic to Europe. And it was in these camps, which were built to accommodate large numbers of people, but which in fact accommodated a lot more, that fever broke out and a lot of people were hospitalized and large numbers of people died. Initially, the cause of this was known to be a pneumonia, but the cause of pneumonia was unknown. In these camps, doctors, health personnel were affected equally, as were soldiers who came from all parts of America. They spoke between them nearly 50 languages. And because it affected the health personnel, doctors, nurses also were depleted in numbers in these camps as they died in equal proportions to the general population. But even in such a crisis, racism was not dead. So here you have a picture of Black American nurses who were posted to these camps, and they were unable to function in these camps, although there was a dire need for them, because their segregated quarters were not ready. And this was remarkable that in the middle of a health crisis, this occurred. The Black American soldiers, the vast majority of them were actually the supportive labor for the American troops, but there were fighting battalions of Black Americans. They too were affected by this, but they were segregated. And this segregation might have actually helped them because the morbidity, the actual disease in them was less, although they died in larger numbers. But it's interesting that there were all sorts of theories about why they died more than their white counterparts. Later analyses by historians would show that they actually received smaller rations than their white counterparts, and this could have affected mortality. I put this up because it is a stark reminder to us that public health is more than just the delivery of health care. And that in this case, as an example of racism in healthcare, it tells us that public health has structural and systemic issues which need to be dealt with. As a subject, public health was not very well developed at this time. And so in 1920, we have this remarkable article in the journal Science written by a physiologist who is asked by two of his students that they want to get into public health and what does he think about it. And he says that I told them it was a wonderful thing to do, but he couldn't actually explain to them what public health was all about. And so he thought about it and wrote this article. And in the writing of this article, he attempted to define what public health is. And of course, the colors are mine, and it's not merely to show you that I know where the color icons are for different things. They just tell you different types of what public health constitutes in terms of its various aims that it fulfills. So it obviously deals with populations. It has an intent which is very different from that of medical practice or clinical practice. And if you notice here, there is a line which says, and the development of the social machinery. So they are clearly looking at issues within society which govern public health. And they look at a standard of living, which speaks to us today of the social determinants of health. But it wasn't labeled as such at that time. I want to take you to a time when this man, Jani Beg, was a great historical figure, great in the sense that he had a lot of impact. Jani Beg was part of the Tata army which crossed the Asian steppes and laid siege to a town called Kaffa in present-day occupied Crimea, part of Ukraine. As he laid siege to this a town with a very large fortress and a port, he was unable to actually breach the fortress. And at some point in time, his soldiers started dying. He realized at that point in time that they were dying in such large numbers that he had to give up his siege. But as a last attempt, he catapulted his dead soldiers into the city. This was an act of bioterrorism, although it was not known in those terms at that time. And as these people were catapulted into the city, these corpses, disease spread across the city, and people started dying. It was a port, so there were Venetian and Genoese traders in the port. They ran to their ships, they took to their ships, and in the process, they transported the Black Death or plague to the rest of Europe. It's likely that the Black Death actually went through other means. And one of the poets of the Renaissance, Petrarch, he writes this line, which now may not sound so striking to us, but if we hadn't gone through the pandemic, we might well have actually agreed with him. He says, "O happy posterity who will not experience such abysmal woe as the Black Death, and will look upon our testimony as fable, as though it was a story, and no one would ever believe that a pandemic like this could ever occur." But this pandemic did occur. And as it occurred, states could do very little about it. They just saw the deaths piling up, people dying of the plague. The mortality at this time is estimated to be between 40 to 60% of the population. It literally wiped out the population, and it had such an impact that it affected poetry, it affected prose. The writer Boccaccio would leave for us in his book, The Decameron, some of the clearest depictions of the plague. And he would talk about cities where cartloads of waste would be carted out of the city in a desperate attempt to stop the plague, but it was too little, too late. And it affected artists as well. Here you have a painting by Pieter Bruegel, the elder, who was a Dutch and Flemish painter. He titles this The Triumph of Death, and he paints this over 2 centuries after the plague, but it is so vivid in his imagination because the memories of that have lived for so long. The Great Plague had huge effects. It had social effects, it had economic effects, it had political effects, and the population was decimated. There was, imagine Europe where there were no people to till the soil. Shops were open, and even as shops were open, he talks about wine stores being open, and no one would enter those wine stores because they just didn't want to go out and get the plague. Imagine that, okay? It had huge things. And of course, it led to something that we now call scapegoating. So I'm sorry about that. I've obviously, in my enthusiasm, done something which I shouldn't have. So we had scapegoating because someone had to be held responsible for the Black Death. And so some population had to be held accountable, and who was held accountable were the Jews in Europe. And so you have this massacre after massacre occurring across Europe because they were held responsible. Now, the Great Plague was a time when states or nations could do very little about this pandemic which had hit them. They buried the dead, And while there was no equity in life, there was equity and equality in death, because massive pits were dug, and the rich and the poor, the rulers and those who were ostracized in society were all buried together. But the Great Plague had impact, because it forced nations to ask themselves the question, how would they respond to a similar occurrence if it occurred later? And so, although this plague was highly successful in that it killed a lot of people and it made a lot of people sick, nations subsequently developed the tools to deal with it. And so Venice and Genoa and all these trading cities now set up, this is a map of Venice, the lagoon of Venice, and circled in that is what we call a lazaretto. It was an island where, if there was an epidemic, ships were not allowed to berth at the regular jetties. They had to go to these islands. They had to fly a flag to show the state of health of the ship, and if there was anyone sick, they were diverted to these lazarettos. This is an artist's depiction of that. And then they were kept there for 40 days, hence the term quarantine, okay? And of course, this period of the quarantine was always changed. It became 30 days because merchant states suffered if the ships could not unload their products. So all those things happened. But the state intervened in order for collective good, all right? And the notion of quarantine has, of course, continued through the ages. I want to take you to a period much later than these plagues and all this. This is a man called Bismarck. He was the unifier of Germany. He takes on the French. He marches into Paris under this Arc de Triomphe, and he tries to. The reason he embarks on this military adventure is he feels that Germany had earlier suffered in the hands of France, Napoleon Bonaparte, and all that. But that's not why I'm talking about him, because in 1884, he was responsible for the first national health insurance scheme. Under this scheme, he covered all industrial wage earners. They were required to contribute a part of their pay. The employer was required to contribute something towards them. And in the process, they were given free medical benefits. Their hospitalization was taken care of for a period of time. And the impact of this scheme was that in industrial workers, mortality fell by about 8%, but not just in the workers, in their families as well, who were not covered by the scheme. And you might wonder, why did the mortality fall in them? Well, it's believed that all the hygienic measures that were instituted for the factory workers were used by family members, that diffusion of knowledge and hygiene occurred, and the mortality fell. This led to the notion that the state, the nation state, has a responsibility to take care of its citizens. And the ethical framework that I've just described was what we call paternalism. The state behaved paternal. The state behaved like a benevolent and loving father, presumably doing everything for its citizens. And over the years, paternalism has become an established concept, because even in our own countries, we recognize that there are rules which govern our behavior. We cannot smoke in public. You should not be using your mobile when you drive your car. And there are other ways that paternalism acts. And we recognize now that there are basically two forms of paternalism. One is hard paternalism. There are rules, there are laws, there are penalties if you don't follow these things. And then there is libertarian or soft paternalism, where you are nudged, into doing things which are beneficial for you. For instance, a musical staircase which increases physical activity, or those footprints and handprints which increases hand washing after the use of the toilets. This is based on what we now know and call nudge theory. Now people argue that paternalism is all fine and well if you are a truly benevolent father. But who really makes these decisions? How are these decisions made? Are these decisions always fair? And you could keep asking all these questions and many more, all right? So paternalism is an ethical construct. It continues to exist in public health today. Look at this period in history called the Industrial Revolution. The Industrial Revolution was a time when all the colonies provided all the raw material for the colonists. The colonists in turn used the raw material, manufactured goods came back to us, and we made them rich and we became poorer, right? But in order to fuel the Industrial Revolution, cities grew. And factories within the cities started spewing out large amounts of smoke. In fact, London was referred to as the great or the big smoke, because you never saw the sun, you never saw the skies, and not only in London, but in all the industrial cities like Manchester, and that's what's actually depicted in this picture. Charles Dickens, who was one of those great writers of the Industrial Revolution, talks about smoke coming down from chimney pots like flakes like snowflakes. So thick was the smoke that was coming down. And the poet Shelley just simply said, hell is a city like London. So if you could if you could never envisage hell, well, think of London of the time. The Industrial Revolution caused huge numbers of people to come into the city to work in the factories. And there was this growth of slums. Our living conditions were terrible. In countries like India, we were considered the white man's burden. They had to look after us, right? That's how they characterized the nature of colonialism and their role in it. But actually, at that time, health conditions in their own cities were as bad as anywhere else in the world. And you see this in this picture of the slums. And so bad were the health conditions that this man, Edwin Chatwig, was asked to conduct a study on the slums of the United Kingdom. And then in 1842, towards the end of that 1750 to 1850 period of the Industrial Revolution, which is really the period when factories were growing at a rate which was phenomenal, he brings out this report on the sanitary condition of the laboring population of Great Britain. And he suggests that the ways to address this is actually to deal with their living conditions. Because when the cities grew, the rich just moved their houses from the center of the city back to the periphery, but the city kept growing. And at some stage, the rich realized they just couldn't keep going further and further away. Few years later, 1848, we see is a year of revolutions throughout the world. Women are fighting for their right to vote. Women are fighting to be counted in their countries. In most of these countries, women were considered minors. They were considered the property of their husbands or their fathers. And they were fighting about this. But there was a general sense of revolution in Europe. It was also the year in which the Communist Manifesto was released. But in terms of health, it marks an important time, because it was the time when this Public Health Act in Britain was formulated and released. It was an act which suggested that there should be boards of health which look after every locality. Now, it wasn't an act with a lot of teeth, because it didn't give the boards of health enough to do about what they were doing. But it was a start. And this public health would be changed as we went along. But importantly, the Public Health Act was then followed by urban laws which addressed the state of housing, which addressed the state of water, which addressed nutritional state of the population, and the disposal of waste. And when those laws were enacted, something remarkable happened. This is a graph of deaths due to tuberculosis. It starts in 1855, and then you have the deaths right up to 1964. You will notice that right from 1855, you have a remarkably steep reduction in the deaths due to tuberculosis. There were no antibiotics. There was no vaccination. If you look at this, you will find antibiotics come somewhere down there, right after around the Second World War. And the BCG vaccination on a mass scale, even later. And yet you see this remarkable decline. The decline because of an improvement in social conditions, okay? So how were these actually, what was the ethical response that generated this whole, the ethical framework which generated these measures? To a large extent, this was informed by this man called Jeremy Bentham. This is an auto icon of him. It's a skeleton with a stuffed, his face is recreated, and it sits apparently around the student center of the University College of London. And what Jeremy Bentham said, and I will paraphrase, was that you work towards the greatest happiness for the greatest number of people. He actually said that it was desirable that everyone is happy. But in the event that that is not possible, you aspire for the greatest happiness for the greatest number. And over time, this has been modulated to say the greatest good for the greatest number. But when Bentham formulated this, this idea, he then had to define what is happiness, because that wasn't easy to do. And so he created a whole lot of things. He said it depends. He posited that there was pleasure and there was pain. And he said happiness is when we have a lot of pleasure and very little pain, but our intensity of pleasure can vary. If we increase the duration of pleasure, well, then that's better. If whatever we do as a measure or an intervention with certainty provides pleasure, then that is good. And then he said, if it acts fast, if the measures that we have act fast, that is good. If pleasure creates more pleasure, fecundity of pleasure, he called it, that is good. So he created this whole thing. His view is called utilitarianism. And it belongs to the school of thought that we call consequentialist. Why? Because he decided what was good and right was based on the consequences, giving happiness, creating good for the maximum for the maximum number. So it does raise the issue, do the ends justify the means? Because he was essentially looking at the ends. So utilitarianism attempted to maximize pleasure. In time, a subsection called rule utilitarianism evolved, where laws were created which would allow populations to derive pleasure, which would be of benefit to the pleasure. But even if those rules did not exist, there was an alternative. They said, if you're going to intervene, then the act by which you intervene should provide as much maximum pleasure or happiness or good or benefit as any other action which could have been thought of. All right? So, but the critique of consequentialism or utilitarianism is that while it looks at the great benefit to the greatest number, there are always going to be people who are left out. And the question is, do they matter? There was also the issue that many people said that Bentham, in his original postulations was impractical. I mean, who's going to make that decision about fecundity, intensity, all this? They said people don't work that way. We just use common sense. Some suggested that it robs people of you're actually thinking for people and you're robbing them of their individuality. And then others suggested that even to think that we can provide solutions for the maximum benefit to the largest number is an arrogant notion, that you could actually even do that. One of the other utilitarians was this man called John Stuart Mill. His father worked as an assistant to John Bentham. This is the son. And he also believed in utilitarianism, but he's important for several reasons, but I'll name two. The first was that he suggested the importance of liberty. If you actually look at the COVID pandemic and you see in the West people who are anti-vaxxers, anti-maskers, a lot of people actually take their inspiration from Mill, who suggested that your liberty was very important, provided you did not harm anyone else. And so in proposing the necessity of liberty, he also introduced an important principle in public health, which is called the harm principle. Okay. Now, unfortunately, people forget that Mill was a utilitarian and then focus entirely on his papers of liberty. So consequentialism and utilitarianism is another framework for public health ethics. In 1972, newspaper reporters broke the story that there were Black Americans involved in a study, which is very famously called the Tuskegee study. They were diagnosed with syphilis. They were followed up for 40 years. They were never told that they had syphilis. And when penicillin became available, they were never treated. And this study continued. You could argue why Black Americans, did white Americans not get syphilis? They did, but this was a study on Black Americans. And it was only after this newspaper reporter broke the news of the existence of this study that people started wondering how this study could have even continued in America for such a long period of time. It was a study that was supported by the United States Public Health Service, all right? At about a decade earlier, in the 60s, you have two very important publications which emerge. One is this book called Human Guinea Pigs by Papworth, where he talks about research in the highest seats of learning in England, which he believes are unethical. And shortly after that, Beecher publishes an article in the New England Journal of Medicine, where he starts looking at the same, what he sees as unethical research practices in England. In the United States. I actually have talked about this because my next story is a story which brings in research and syphilis together. It has its origins in that Tuskegee study of Black Americans who had syphilis and who were never treated. In 2010, this lady called Marta Orellana was interviewed on television, and she says this: they never gave me a chance to say no. What was she talking about? Well, in the 1940s, the United States Public Health Service, apart from running the syphilis studies in Tuskegee, embarked on a study in Guatemala. Guatemala was a poor country. They talked to the government. The government agreed to be that its citizens could be part of this study. The studies were again funded by the United States Public Health Service. And what the study aimed to do was to look at the prophylactic benefit of penicillin, which was a relatively new antibiotic, in preventing sexually transmitted disease. As a part of this study, doctors infected soldiers, prostitutes, prisoners, mental patients, I'm using the words that they used, with syphilis and other sexually transmitted. They didn't have it. They initially attempted to inoculate them, to infect them with these diseases. And then while a majority of these people were treated with penicillin, many weren't. The study had deaths. The deaths are not directly attributable to sexually transmitted diseases, but they did die. And this study actually came to the fore when a historian called Susan Reverby, who was investigating the Tuskegee studies, looked at the files of one of the investigators called Cutler, who retired as the dean of, I think, public health in the University of Pittsburgh. And in the basement were all his boxes and files. And as she went through them, she was shocked to discover that there was this additional study in Guatemala which no one had ever heard of. Okay? And so this is where this lady, Martha, was interviewed and where she talked. She was part of the study. The study lasted for only about 3 years. It was stopped partly because of medical gossip. And clearly, if it stopped because of that, then they were aware that what they were doing was perhaps ethically unacceptable. And partly because, although this was a study where pharma was involved, penicillin was not enough. And so you ask yourself, how did they embark on enrolling so many people and infecting them when they knew that they did not have any penicillin? And these findings were never published. Had it not been for Susan Reverby, we would have never known that this study existed. I'm going to move on to yet another study, because this illustrates the ethical framework, which I'm going to talk about after this. This is the Havasupai tribe in America. The University of Arizona recruited them. A lot of the native Indian or First Nations peoples suffered from obesity and diabetes as a result of laws which took them away from their lands, disenfranchised them, and it resulted in a loss of kinship, a loss of social coherence among those groups. They developed diabetes. I remember as a postgraduate reading about the Pima Indians and being fascinated about it without ever realizing that at the heart of their diabetes and obesity was not just a physiological phenomenon, but was a historical injustice for which restorative justice was never ever achieved. But in these studies, the investigators wanted to look at diabetes, and the tribal leaders gave their consent. They conducted the studies, but they didn't find anything that was significant or which they were looking for. And so, because the samples were stored, the blood samples, they had the data, they started doing other studies. And this study actually came to the fore because at one of the meetings in the University of Arizona, they are discussing these findings. And seated in the audience was a member of that tribe who was attending the university. And she was shocked to see that all these things were being talked about her tribe, because in effect, what it was doing is it was stigmatizing an entire tribe. They sued the University of Arizona. There was a settlement which was achieved. But this leads to another framework of public health ethics, of which Rawls, Harvard professor of ethics, was a part of. There are many other people who contribute to this. And he put forward this theory of egalitarianism. It was basically a theory which was focused on justice. He talked about justice as fairness, where we consider everyone as being equal, everyone as being worthy of our attention. He suggested that this didn't work against libertarians, because in the United States, people focused ethics on autonomy, on their liberty. And he said it doesn't actually impinge on that. You can have liberty, provided you do not affect the liberty of other people around you. So you preserve your liberty, allow them to preserve them. I'm paraphrasing, of course. And he also said that there was an important thing called the difference principle, that while disparities exist in society, those who have more have a moral responsibility to contribute to those who have less, so that society can move together and it is more equitable. But importantly, he also proposed the principle of equality of opportunity, that every person in society should have an equal opportunity. And this becomes important because it lays the foundations, and he wasn't the first to suggest it, but it lays the foundations of a framework for public ethics, which we might broadly characterize under social justice. So social justice has many elements. It has the elements of including people in decision making. It ensures that the benefits of whatever we do reaches everyone in society. It's not directed only to a few or to even most or even to many, but it reaches everyone. And it speaks to two ideas, the idea of solidarity and of subsidiarity. What is solidarity? Solidarity, when I say have solidarity with someone else, we tend to think of it as, oh, I should show compassion to that person. I should feel for a person who's going through something. But solidarity isn't a vague sense of compassion. It is an understanding that we are intimately connected with each other in a world which is interconnected. And that whatever we do acts towards something that we might call the common good, the benefit of everyone. On the other hand, subsidiarity refers to the voices which don't get heard. The voices of those people who underwent the syphilis studies, who were forgotten for 4 decades before a historian actually raised their issues. The voices of those of the Havasupai tribe who were forgotten until the issue was discovered by one of their own tribal members. So subsidiarity refers to looking at those populations which may be unaddressed, may not form the majority, but should have their needs addressed as well. There's a historian, Italian historian called Gramsci, who actually refers to a term called social hegemony, where he says that the world will always have people who are powerful and those who are not. He's not talking about majoritarianism. This is not about majoritarianism and some people at the periphery. He's talking about people who hold power, the powerful versus those who do not have the power or who are unempowered and cannot speak for their needs. So social justice was another framework of public health ethics. And it begs the question, why should we even be bothered about health? Is health of special moral importance? I mean, there are so many needs that we have, right? Why should health be considered separately? And there's this wonderful book by Norman Daniels called Just Health, and it's a pun on those words. And he uses the theory of Rawls to say that if we all have equal opportunity, then by keeping people functioning normally, by ensuring everyone functions normally, we actually protect that opportunity. And health ensures that people function normally. Therefore, health is of special moral importance because it contributes to the range of opportunities that exist with us. And then the question that then follows naturally is, when are health inequalities unjust? Can there be health inequalities which are just? Because at the end of the day, we live in an imperfect world. There will be inequalities. And again, Norman Daniels starts off with the premise that social gradients exist. We cannot do away with it. There will always be social gradients. But a fair distribution or distributive justice as part of that social justice framework requires that all socially controllable factors, whether it is shelter, food, water, or access to healthcare, should be available to all. And he calls these socially controllable factors because they are within our control. Therefore, he says inequalities that exist after fair distribution of all goods through the social economy can be called just, because we've done everything to ensure. So those inequalities which remain are perhaps fair inequalities. And then, by using the same logic, inequalities that exist because socially controllable factors are unequally distributed are unjust. He's speaking to the social determinants of health. The idea of social justice is constantly evolving. It's constantly changing. We are faced with a climate change crisis, with an assault on planetary health. Last year, very close to where I grew up, we had these massive floods, which were extremely destructive in nature. The Teesta River in Sikkim is one of the fastest flowing rivers. And when you have these massive rains which exist, the speed of that river is quite unbelievable. But it forces us to rethink what social justice is. Is social justice merely about what we are going through now and what the needs of people are now? Or is it something more? And with this has emerged the idea of intergenerational justice, where we are talking about social justice not in terms of just merely what I am facing, what people today are facing, but even for those who are unborn. In 1991, a very remarkable paper was written. It was a prescient paper on climate change and the ethics of it. And the author at that time suggested, at that time in 1991, that when we work with the environment, we are borrowing and we are destructive of the environment. We are borrowing social capital, which we cannot return. He was referring to what would happen to generations afterwards. I don't like this rather awkward term, but it's a term which has now come into the lexicon of ethicists. It's called long-termism. We don't think about what is good and fair and just now, but we look at what might be the result of our actions many decades later. An historian, French historian, Braudel, referred to this as longue durée. We look at history in terms of not what it has an impact immediately, but what it has in the long term. So social justice is an important issue which we need to deal with. I'm going to go through very quickly through something else which happened. In 1981, we had the outbreak of HIV/AIDS. Within a year, a fair number of patients were diagnosed. It was initially labeled GRID, gay-related immunodeficiency. By the second year, we start seeing the appearance of the AIDS in hemophiliacs. It is affecting women. We see other presentations of HIV/AIDS, and it is, of course, an ongoing pandemic. And the response of society to this is one of angst, one of hate. Politicians tend to respond to this largely apathetically. They see a very small group of people are being affected. It's really not much of their concern. And this continues for a period of time until HIV and AIDS begins to walk into the doors of politicians and people of importance as it spreads more and more. And we now begin to see a major movement because HIV/AIDS is, in its early years, is characterized by something which people would refer to as social death. The person who was diagnosed with HIV/AIDS at that time was dead already. They were isolated. They were waiting for physical death to happen. And this was not a new phenomenon. Leprosy was always stigmatized from very early ages. And in medieval England, people with leprosy were called to the church, and outside the church in the courtyard, the funeral rite was read. And in a funeral, the coffin is lowered and mud is thrown. In medieval Europe, the leprosy patient, after the funeral rite, mud was thrown at their feet and they walked out. They were dead already. HIV/AIDS exposed us to this social death. Pharma companies developed new drugs, but the rates at which these drugs were available in the initial years was so expensive that even only the richest in developing countries could afford the entire year's supplies of drugs. And that led, of course, to a huge civil society movement which called for these drugs to be made available at a lower cost. They held pharma companies to account, but it also led to a movement of ethics which was based on rights-based ethics as a formulation for public health ethics. Many people would refer to human rights as the currency of international monetary discourse, because, of course, the Universal Declaration of Human Rights, which most countries are signatories to, came about in 1948. It included political rights, it included social and economic rights. But strangely enough, as time evolved, these rights became dichotomized. They became dichotomized because the focus appeared to be on political rather than social and economic rights. And in part, it was driven by world politics, because the Cold War pitted the Western world against the communist world. The Western world would look at the communist countries and say, you are in breach of all the political rights. And the response of the communist countries, regardless of the state in their own countries, was to point to the West and say, well, you have huge socioeconomic disparities. Where have you made social and economic rights accountable and legally defendable? Because even today, you can go to the International Court of Justice because of breaches against humanity, atrocities, genocide. But you cannot go to the International Court of Justice and say, we're not getting enough food, or the shelter that people are living under is inadequate. And so there is a problem of even defining human rights. And so there are huge numbers of questions we could ask. There are questions which I've put up. These are, of course, just the tip of the iceberg. So in this talk, what I have attempted to do is take you through different constructs of public health ethics. I started with paternalism. I moved on to utilitarianism, ensuring the maximum happiness for the greatest number. And then to social justice, the issue of distributive justice, commutative justice, a whole lot of social justice principles. And finally, back to rights-based ethics. But we could actually ask ourselves, are there overarching principles that we could look at through all these? And I think one of them is transparency, right? We would all agree that transparency should be a key principle which should govern all public health ethics, regardless of which framework we use. We would also probably agree that trust is an important issue. Public health ethics works when we trust those who are in power, who are actually making decisions sometimes on behalf of the rest of the population. But I think, for me at least, a critical principle which we should embrace is that of human dignity. Because when you look at human dignity, we often use the phrase, Let us dignify them. Let us treat that person with dignity. When we use that, and I know Father Charles is here, who's the expert on dignity. He's written a big book for you to read. And human dignity is not what we bestow on other people. Every person has human dignity. It's something of intrinsic worth. Regardless of our station, regardless of our religion, our caste, whatever we are, we have intrinsic human worth. And that is the foundation of human dignity. And I believe that all these frameworks that I've talked about have as an overarching principle that notion of human dignity. If we subscribe to the idea of human dignity, I think a lot of the other principles which are espoused follow. Thank you.
I think we are open for questions. You can just switch on your mic and then ask the question.
It's very clear that I've solved all the ethical issues of the world and of public health. Oh, sorry. This is an in-house question.
And raise the question. No, what's challenging, and I suppose ethics is challenging, is the role of individuals in what seems to be factors that are influencing public health ethics. So if you could just, it seems like it's a vicious cycle of individuals trying to make a difference, but how much do individuals truly influence that change process?
Yeah. Unfortunately, I think that individuals or groups of individuals have an influence which is far greater than they should have. There is an increasing move towards getting people from the grassroots to actually determine a lot of public health interventions. What, in fact, typically happens today is that they happen from top down. So when you talk about the role of individuals, I think one of the, I don't have a solution as a simple thing, but I do have a slide, if I might, which actually speaks about what our individual roles are. We might actually, as individuals, take the view that, okay, ethics really doesn't matter. I don't care, all right? But then I think that what we need to move is a sensitivity of ethical issues. Actually, just the simple understanding that is there a problem? Because if we cannot identify an ethical problem, then there is not much that we can do about it. So the first step is actually knowing that there is a problem. And then if we know that there is a problem, we can respond again with apathy, or maybe we move on to have concern, which means, is there something that I could possibly do something about it? We could become advocates, right? And advocacy is not a structural issue. Individuals can be advocates for change. So do we speak out for change? And finally, of course, we could be part of the action that occurs. I think increasingly there is a realization that public health policies are what they are. They are policies. And very often policies fail because they cannot be implemented in a population, or what happens in a population is unforeseen or unknown to those who actually make policies. So I think action is where it devolves down to groups of individuals at the grassroots and possibly through individuals. I think all of this is all possible only if we are informed, we are grounded in reality, and we are rational. I know I say this because there is a general sense that activism is irrational. And I think that is not true. A lot of activists are extremely rational in their point of view, and they have given it far greater thought than I think many people would have given who formulated policy as well. But I think there is a move towards devolution. The extent to which this is possible is actually varies from country to country and depends on, of course, empowerment and a lot of structural issues that go along with it.
Thank you, Dr. Vaz, for your very enlightening presentation. My name is Sharon. So my question is this: in any medicine trial, are control groups ethical? So there's neither transparency nor human dignity in that. Because if it's a blinded trial, no one gets to know, and one is suffering from the disease, but gets a placebo instead of the medicine itself.
This is not really what I have talked about, but I think it's a relevant question that you've asked. I think for any clinical trial to proceed, one of the conditions that needs to be fulfilled is that of clinical equipoise. And so that means that if there is a treatment arm, and if it were known that the treatment arm is going to provide benefits, then there is no need for the trial. There are placebo trials, and there are those which have standard of care as well. All right. And regarding transparency, there has to be transparency. I think that is what institutional ethics committees are part of the process of trying to ensure transparency. Of course, we can view trials where the issue of consent, of information, is not in the hands of the committee which oversees ethics, but in terms of investigators. And is there a need for investigators to invest more in that process? Yes, I think there is. But the mechanisms to ensure transparency are actually there. So when a person enters a trial, they enter a trial knowing that there is equipoise. There is no guarantee that the treatment that is being tested would prove more beneficial than standard of care. And for that reason, they are aware that they could be in a treatment arm or in a control arm. And if the treatment arm begins to show dramatic changes of improvement even before the end of the trial, they are ethically required to stop the trial so that actually the benefits can be transferred. So there are things in place which attempt to address these issues.
So we have some questions coming in the chat box. I'll just read out it.
Okay.
So what are the principles that are being ignored when pharma companies do large number of clinical trials in developing countries? And what can we do to ensure that they are ethical?
So again, I think clinical trials are not necessarily a part of public health ethics. I think the issue that is raised is relevant because the reason why pharma companies go to developing countries is, of course, for several reasons, not only because they want to be unethical and perform the trials in developing countries. They are often addressing issues which are prevalent in developing countries. But there is no doubt that the ethical regulatory bodies in many developing countries are not strong enough to provide the oversight that would be present in developed countries. Okay, and that is a matter of concern. I think there are many issues to do with these studies. The issues are finally, even if a drug is found to be beneficial, will it be made available in the countries where the trials were conducted and at a cost which is affordable by people, or which would be accessible to all people in those developing countries? And I think there is also a sense that, and this, I don't want to make a blanket statement, but there are reports that the costs of developing drugs might have been overestimated by pharma companies as a means to actually justify why costs at the end are much higher than what we would want it to be. All right. There is a lot that has to be transparent. I think developing countries have to strengthen their own regulatory frameworks. Until that happens, and until we have bodies which hold these companies to the standards that they would follow in developed countries, there will always be loopholes, but these would close as more and more countries develop and implement their regulatory. The fact that these are huge companies and the worth of these countries is often more than the worth of the GDP of countries where they're going to, is of course speaks to the idea that money actually is an important issue. I don't think there are simple answers to that question.
Thank you, sir. Another one. So should
Yes, also.
individual so your thought on should individuals have the rights to refuse vaccination for themselves or their children, given that public health risks that would come along with that? Even as researchers, we do also see those things. As patients, they refuse vaccination for their children. So what do you think can be done? Your thought on this?
So it's not so much what I think as what are the possible options. In societies which follow hard paternalism, there would be consequences to not vaccinating. I mean, there are countries where if your vaccination status is not complete, you can't enroll in schools. So that is an issue. The shift from hard to soft paternalism has really come about because people have recognized that by being coercive, you actually cannot do very much. All right, it's not like you can force everyone to do everything that you want them to do all the time. So, ethics doesn't provide necessarily the simple solution. Obviously, you would want to appeal to people to vaccinate themselves for the greater good. There is always going to be that tug of war between personal autonomy, your personal choice, and collective responsibility. But we must also recognize that people sometimes react because of what is happening. So regarding the COVID vaccine, you all know that AstraZeneca has withdrawn its vaccine, ostensibly because there is no demand. But there was also a court case that was happening where the company, to the best of my knowledge, agreed that some of the side effects which led to the death of individuals could possibly have come from the vaccine. Now, this plays on people's decision to choose to vaccinate or not. And unfortunately, episodes like this, as well as the, I don't know how many of you all remember that the MMR triple vaccine was at one stage reported to be associated with autism. And later on, this was a paper published in The Lancet. It was found to be erroneous. The person who led the paper was held accountable for that. It took 12 years for Lancet to fully withdraw this paper. But in the meantime, the effects of that were already felt because people stopped vaccinating. And there is a fear. And right now, for instance, and they stop vaccination not just against MMR, but against other conditions in the UK are now beginning to see a surge in whooping cough. So unfortunately, there are many issues which determine this. It's not just personal choice is not just, doesn't come out of the blue. There are reasons for personal choice. We need to understand those reasons to be able to intervene effectively. But there will always be people who will refuse. Yeah, I don't know. Do you want to? Okay.
Good evening, sir. It was pleasure listening to you. I'm here. I'm Dr. Archana from the Department of Community Health. So my question is, in my observation, whenever we discuss ethical issues, we always discuss about the Tuskegee trial or the Nuremberg Code or studies which have been conducted in African countries. But we hardly discuss anything related to India. Why is it that? Are there no ethical issues from an Indian point of view, or is it not being documented anywhere?
Yeah. So I have actually purposely chosen issues which are not related to India, not because they don't exist, but because I do hope that when you all go out and you all search, you all will find all these issues that you're talking about. The Indian Journal of Medical Ethics, which is a freely available journal online, you can access it, and all back issues have large numbers of issues related to India. Okay, so the issues exist. In public health, I personally would not like to keep going back to the Nuremberg Code. The Nuremberg Code looked at studies which were done in Nazi Germany in the concentration camps. The Nuremberg trials held those people accountable. But one of the things which came out of the Nuremberg Code was the issue of personal autonomy and consent. Okay? And in public health, putting that on a pedestal actually creates problems when you're looking at the issue of communities and populations. Not to say that your personal autonomy is not important, but that is precisely the libertarian view which exists in many countries in the West, where the personal autonomy takes precedence over the common good or the public good. Okay, so there are lots of issues. Please go through the Indian Journal of Medical Ethics and you will come across many, many issues. The HPV vaccine in India is one of them, but there are any number of issues which are discussed. Welcome.
Good evening, Dr. Mario. I have a question on the recent pandemic. Largest, let's say, public health problem in a century. In this, the distribution of vaccines was inequitable, even in developed countries, but more so in developing countries. There were large issues of ethics involved. For example, there was rampant capitalism in terms of profiteering because of insufficient vaccine, etc. So that is also an ethical problem, because ultimately at one stage it's a free capital market issue. But when it's when the situation is such that it's a large public health problem, then shouldn't there have been some code by which they should have been forced to? A simple statistic is that BioNTech, one of the major players in that, had virtually nil revenues before they started this. And they overnight had $10 billion. So could you address this?
Yeah, I think what you're, when we talk about public health issues, of course, they exist within countries and also between countries. And the pandemic that you talked about is something that we acutely remember because we went through it. There is no doubt that there was the inequitable distribution of vaccines, but there has been for a long time an attempt to try and work out global ethical standards. And although many people, and I think very beautiful articles have been written and wonderful codes have been written, I think because of inequity in the world itself, these have really not been able to be implemented globally. And the COVID pandemic is not the only pandemic which illustrates this. The largest ongoing pandemic is HIV/AIDS. And if you look at the number of deaths that have occurred, the disproportionate deaths that have occurred in developing countries as opposed to developed countries, it's a stark reminder that this inequity exists. And I don't know whether there is any way that you can do it. I think with the COVID pandemic, there were attempts made to try and procure vaccines, to try and distribute them in countries where they were needed. But again, procurement has to be from a source. And I think there were all those barriers that existed, as well as stockpiling, and stockpiling manyfold in countries which would never ever use it, so that ultimately vaccines were actually being destroyed because they had reached expiry dates. I think the issue that you raise is something that people recognize. I don't know, I just don't know if anyone has has been able to evolve a framework. And you talk about forcing people, well, that's one of the issues of a rights-based approach. We have not succeeded in actually forcing people to ensure social and economic rights. The rights that are constantly, right now, South Africa is presenting its case to the International Court of Justice again regarding the Gaza and the Israel intervention in Gaza. But where do you see social and economic rights? There's actually no forum which holds people accountable. And the justification for that was that when countries were at such different levels of development, you could not hold them accountable to a common standard. So these rights were always, in a sense, aspirational, and they have remained that way. No, I can stand. Sorry. I think no, it's the volume is not very, you may have to come closer to the mic.
This is Dr. Sri Lakshmi from Srimati VHD Central Institute of Home Science. The flow chart which was displayed there, that made me to think for the homeless people in US. These days, we are seeing them more and more, and US being a very developed and one of the strategically planned country, and they have many public health institutes, but still the problem is arising day by day. Is there any organization working for helping them, so that because they are not caring for themselves? That's very, very pathetic condition, very untidy living, no bathrooms, and even publicly they are doing all the urination, etc. Is there any organization who is helping them or doing research on this aspect? I would like to know, Doctor.
I don't know specifically about which organizations work for the homeless in the United States, but you actually bring an important point, because in the United States, there is a tussle between how much should the state intervene for any of these issues. That is where actually paternalism is seen as something excessive. People refer to these states as nanny states because the state is constantly intervening with everything that they are doing. And I don't think we should necessarily look at the United States as an example of what is best practice because clearly there are large inequalities. There are other countries, for instance, the Scandinavian countries, which have social welfare models, which have better tackled the issues of inequity within their societies. So, I actually have nothing to say about the United States, but I don't know really. And
There are public health institutes. Especially they don't have proper food, sanitation, and hygiene. That is where I'm concerned.
Well, the libertarian view would say that, you know, people should work harder to actually get, there's no reason to tax those who are working very hard and doing, earning their hard-earned money and then taking that and giving it to someone else. I'm not saying I subscribe to that view, but I'm just saying that there are these tussles within countries. And so, yes, they are rich and they also have a lot of inequality. Yes, that is a fact.
Thank you, sir, for such an insightful and engaging presentation. I'm sure that today's presentation has provided us with a lot more thought to go back and think and also apply in our own work. I would now like to invite Dr. Lakshmi Jitendran to formally express our gratitude. And inhumane. I really quote this statement because that is very apt for today's talk. Good evening, everyone. Thank you is such a prayer which cannot be seen or touched. It should be felt by heart. I feel honored and privileged to get the vote of thanks for today's special occasion on behalf of NSI Bangalore chapter. Thanks to God Almighty for blessing today's event. Heartful thanks to Reverend Father Charles Davis for joining us and gracing today's event. It's my privilege to thank Dr. Mario Vaz for delivering the essence of ethics related to public health. And I can say all of us who are sitting here and attended this event, we all are related to public health in one way or other. So I think we can believe and we can put into action also. The belief is human dignity. Let us touch this human dignity in all our actions, in all our beliefs. Special thanks to St. John's Research Institute for the venue arrangement. Special mention to Mr. Prajit, Mr. Maharaj and team for the constant support for today's. We will ever remain grateful to NSI headquarters, NIN Hyderabad, Executive Committee, Bangalore chapter for the constant guidance and encouragement for bringing such talks to all of us. Big thanks to all the online and offline participants for your august presence. Words are not enough to thank Dr. Rebecca, especially because she's the one who has arranged all the arrangements, she and her team only. So special thanks to Dr. Rebecca, convener NSI Bangalore chapter for arranging today's event. Thanks to one and all and have a great evening.
Dr. Lakshmi is the co-convener of the Nutrition Society of India Bangalore chapter. Thank you, Rebecca.
Thank you, Dr. Lakshmi, for the vote of thanks. As a token of appreciation, we would like to present a small memento to Dr. Mario Vaz. I invite Reverend Father Charles to do the honors. Thank you all. We would like to invite you to join for coffee, tea, snacks outdoor. Thank you.
Form that you can please get, I mean, we are that in June, on June 11th, we are conducting another online program. We will send the link to you. Thank you. Please do join.